Good morning, everyone, and welcome to day 4 of the Actuaries Club of the Southwest Spring 2026 meeting. Before we begin, a quick reminder, please use the Q&A feature to submit any questions. Since we have approximately 200 attendees, we won't be able to use the raise hand feature, but we truly appreciate your participation and your support of the club. With that, I'm pleased to introduce the speakers for our first session, David Stoddard and Chris Lombardi. David Stoddard is an actuarial director in Willis Towers Watson's health and benefits business. He is based in Short Hills, New Jersey, and has over 15 years of experience in the healthcare industry as a lead health benefits actuary. David supports clients on a variety of projects, including plan design modeling, pricing, claims trend analysis, budget projections, and IBNR reserve estimates. Additionally, he uses his deep analytical skills and strategic understanding of employer total rewards strategies to evaluate programs and make recommendations that enhance plan value, mitigate risk, and bring cost-effective benefit plan solutions. David has supported clients of all sizes from 100 to 100,000 plus employees from a variety of industries, including construction, healthcare, hospitality, manufacturing, professional services, technology, and transportation. Chris Lombardi is a director in Willis Towers Watson's health and benefits business. He works on all financial aspects of the health plan, projecting costs and strategizing methods to sufficiently manage risk consistent with each client's unique risk appetite and business objectives. Chris has over 13 years of experience providing services for clients in a wide range of industries. Approaching his work as a collaboration, he partners with his clients' human resource and financial representatives, as well as the robust actuarial talent pool at Willis Towers Watson, to develop and implement initiatives that meet their needs. Chris is also a people manager, responsible for the coaching and career development of members of the local staff. So, David and Chris, take it away.
Thank you, Tim. Thank you, everyone, for having us here. Hope that we can have a productive session. The title of our presentation is Health Plan Cost Basics, Deductibles, Coinsurance, Contributions, and the Role of Actuaries. The genesis of this topic was one of your leaders came to us and asked if we could put together something related to employee benefits. One of the club members was going through open enrollment at their company and had a question about why a plan was priced in a certain way relative to another plan. It seemed like it was a richer plan than the other plan, but yet it was priced. The contributions required to participate in that plan were lower. And so the question was, well, why is that? And that kind of led to a broader question. Like, you all are actuaries, you probably understand the basics of underwriting, of plan design. Generally a higher deductible, a higher out-of-pocket maximum is going to mean that it would cost more if you use the plan versus a lower deductible, a lower out-of-pocket maximum. So we want to cover that very, very broadly, but then we'll also kind of get into, the nuances of plan design, of employee benefits as it relates to medical and prescription drug, how are contributions set, what's like the overall strategy of an employer when they decide on their benefits budget, when they decide on the plans that they want to offer. So with that, we can get into it. Uh, We were already introduced. This is what we look like, though. Hopefully you can see us on the screen as well. Had I known that Tim was going to read my entire bio, Chris, I don't know if you feel the same. Probably would have shortened it a little bit. It felt a little weird to hear all that, but that's okay. We'll start just kind of reviewing the typical types of plans that employers offer. We'll then talk about how those plans work together to influence both what the plan will cost the employer, the employee, and then how those plans might influence employee and plan participant behavior. We'll talk about the difference between what an employer pays for and the actual overall spend within a plan. There's differences there. And then I'll turn it over to Chris to talk about how employee contributions are set, what strategies are involved there, and then finally some benchmarking and what that means and how employers and large groups can use benchmarking to decide on what to do with their benefits. So the first thing we'll talk about types of plans. this might be somewhat of a review, or you all might be somewhat familiar with this, but there are a number of different medical plans that employers offer. The most traditional or the most common is a PPO plan, preferred provider organization. This is this is what a standard plan looks like. This is a broad network. There's in and out of network benefits. It's fairly flexible, tends to be richer. You don't need to designate a primary care provider. You don't need to see your primary care provider to go to a specialist or to get an MRI or an X-ray or anything like that. It's pretty hands-off in terms of management, in terms of structure, and therefore it also tends to be, on the costlier side of medical plans. High deductible health plans or HDHPs, those are a type of PPO and they are exactly what it sounds like. They are PPOs that have a high deductible and they are typically paired with a health savings account, HSA. In order to be eligible to have an HSA, that it needs to be a minimum deductible. So in 2026, an HDHP needs to have at least a $1,700 individual deductible in order to have an HSA attached to it. So cheaper to participate in. Contributions are typically going to be lower than a traditional PPO, but if you use the plan, you either have to use your HSA dollars or spend money out of your own pocket upfront before you actually get any sort of plan cost share. Point of service or exclusive provider organization plans, those are somewhat similar to PPOs, except that they're a much more tightly managed plan. So the network is stricter, or in the case of the EPO, there is no out-of-network coverage. You typically do, or you might need to designate a primary care provider. You probably need to see your primary care provider to get a referral to use other services. So it's the benefits largely look like PPO plans, but it's a more managed, more tightly managed plan. Somewhat similarly, but in a slightly different vein, a tiered or a narrow network. So a tiered plan, there's an in-network, there's an out-of-network, but within that in-network, within that contracted network, there is a tier one and a tier two. And so a tier one, a subset of the in-network will be designated as tier one. And these providers or these doctors are either lower cost or higher quality or some combination of the two, so that there's an incentive, and that incentive is through lower deductibles, lower copays, things like that. But there's an incentive for a participant to use the designated tier one providers. So the goal here is that members will have lower cost share. They will spend less, but if it's a higher quality or lower cost provider, the plan will also spend less. So that's the incentive there. There is still out of network, and then there is still that broader tier two in network. But the goal is to get members to steer members to use in tier one providers as much as possible. And then finally, alternative health plans. I won't go into too much detail yet. I have a separate slide on this, but these are more non-traditional. They're somewhat of a hot topic as employers start to consider other ways to offer benefits as costs continue to rise. How do we do that? What other ways can we maybe think outside the box and still offer a robust package to our employees without breaking the bank? So this hopefully is a more digestible way to consider the different plans. And I think I kind of reviewed most of this, but I'll focus mostly on the last row there because I went over the basics of the various plans. But then the question would become, okay, given that, who's the best fit for each of these plans? And so, as I said, PPO, it's very flexible. You don't need a referral to see specialists. The costs are going to be fairly high, at least to participate in a PPO. But your costs to use the plan are going to be rather low, right? You're going to have the plan pay for most of the costs, and you might just have copays or low deductibles, things like that. So given that, this would then be best for someone who either has a lot of healthcare services or needs a lot of, they need to see a lot of different providers. And so they need that choice. They need that flexibility. A high deductible plan, you have that high upfront deductible before you really get any sort of cost share with the plan. But the trade-off there is then that the premiums, the contributions that are taken out of your paycheck are lower. As I said, high deductible plans are typically paired with an HSA, a health savings account, and that's really where the main benefit is. An HSA has a tax advantage, a triple tax advantage. So the dollars going in, whether it's from the employer or you're contributing your own dollars, those are pre-taxed. They're not taxed. The dollars coming out, as long as they're spent on medical expenses, those are not taxed. And you can also invest the dollars that are in your HSA in, a normal, like a S&P 500 or, something like that, the way that your 401k dollars are invested. And any earnings on those investments are also not taxed. So it's the most tax efficient or probably one of the most tax efficient vehicles that exist in the US. So a high deductible plan typically is either the right fit for someone who doesn't use a lot of healthcare services. So they'd rather, they don't want to spend a lot out of their paycheck, and or someone who wants to, have another tax vehicle to avoid paying taxes on. POSs and EPOs, like I said, those are more tightly managed. So it's a little bit, it's not necessarily the right fit for everybody. A POS might be the right fit for someone who wants some flexibility, but is also okay coordinating that care through a primary care provider. An EPO would be right for someone who wants to keep their contributions somewhat low, and they don't need to ever, or they don't anticipate needing to use any providers besides those that are in the network. So, you're not getting out of network access other than for an emergency. A tiered or a narrow network, like I said, it's a smaller, curated group of providers, right? Providers that either the insurance carrier or the third party administrator or someone has designated as high quality, lower cost. So they are incented to use those high quality, low cost providers. The plan participant is going to get a lower deductible or a lower copay, a lower coinsurance, whatever it is, for using tier one providers, and then it's going to be a higher copay, coinsurance deductible for tier two and tier three providers. So there's an advantage there as long as you play by the rules of the plan. And so this might be the right choice for someone who, they live in an area where there's strong provider choice. They are okay using those designated providers. They have that access. They don't have to worry about, well, I live in an area where there's only 3 doctors and the closest tier one provider is 40 miles away. That's not going to work, obviously. And then the last one, and again, we'll talk in more detail about alternative health plans, but alternative health plan would be best for someone who's seeking a lower cost alternative. They are probably somewhat technologically savvy. They might be willing to take on a little more risk. And also, they probably need to have a somewhat strong understanding of healthcare. A lot of these plans only work for someone who kind of gets what the plan is trying to do. So alternative health plans, there's a bunch of different flavors. Probably the most common one that I'm seeing right now is a variable copay plan. And if you've heard of Surest, which is a United Healthcare product, or Coop, which is a Blue Cross product, or Simple Pay, which is an Aetna product, these are plans where it's going to look kind of weird if you're getting a summary of benefit coverage or you're looking at your employer's open enrollment package, because for every line item for a primary care provider or for a specialist or for an MRI or an X-ray, it's going to say, copay $10 to $50 or $50 to $300, something like that. It is a variable copay plan. And the copay depends on which doctor you see, which lab facility you go to. And again, it's similar to the tiered network plan where there's an incentive to use lower cost, high quality providers. But this is taking it to the next level. These plans typically do not have a deductible. They have a fairly high out-of-pocket maximum, but as long as you play by the rules, as long as you use those high quality, low cost providers, doctors, it is very unlikely that you'll hit that out-of-pocket maximum. So they also tend to require using an app or logging on, searching out before you actually go to the doctor or go to the facility, because you want to make sure that you're getting that lower copay. So it can be quite disruptive. It's definitely not for everybody. But we have seen, I think, an employer implementing this, not necessarily as a full replacement, but as an option for those that do enroll. We do see pretty significant savings, at least relative to the plan relativity between this plan and a traditional PPO. Direct primary care. This is primary care focused, obviously. So you can go to the doctor as much as you want. Those more routine services are covered and covered for free, but it doesn't really provide coverage beyond that. So you wouldn't want to enroll in this as a participant without pairing it with a more traditional major medical or catastrophic coverage plan. Reference-based pricing is when the employer or the plan negotiates directly with providers, and they would negotiate for like a knee surgery or back surgery, things that tend to have they're high cost. They're somewhat frequent, at least in a large enough plan, but the cost associated with these services, with these claims, tend to be very variable depending on where you go. So the plan will negotiate, okay, we're going to spend $20,000, $30,000 for a knee surgery. It doesn't matter where you go, but then, if they go to a more expensive provider, the member is going to get balanced bills. So it does create that risk to the member that you could pick the wrong provider and end up with a $10,000 bill. ACOs are, and this was a product of the Affordable Care Act. It's a hospital or a group of physicians that will negotiate with the plan, and members are attributed to these physicians or these hospitals, and the hospital, the physicians are responsible for managing these members' care. And if they can demonstrate that there are savings with this group, then the organization, the doctors, the hospital will share in those savings with the plan. So, you look at what they cost last year, you look at what they cost the next year, and make whatever adjustments you need to. And if the ACO can demonstrate that, okay, because they were attributed to us and we were responsible for their care, we saved the plan, 10%, that 10% might be shared equally between the plan and the ACO. And then finally, ICRAs. These are probably, it's a relatively new thing. I've not yet worked with anyone that has implemented it, though maybe Chris, you have, but it's certainly becoming of interest. It's basically an employer decides to get out of the healthcare business. In the same way that a pension plan can be de-risked, healthcare can be de-risked. So the employer decides, okay, we will give you, employee, an HRA for X amount of dollars. Let's say $5,000. Here's your $5,000. You get to decide what plan you enroll in. Do whatever you want. So the employer is still funding healthcare, but it's all on the employee to choose what to do with that money. So the employer can control their costs because they decide how much and if their costs will increase every year, how much they're going to contribute to the plan each year, but they have no control over what the employees choose. So they have no control over what the health of their population. So that's kind of the summary of what plans typically look like. And then the strategy around that for an employer is, okay, let's decide what's best for us, for our employee population, and we can, offer a few different types of plans, a few different flavors of plans. Considerations being, are we offering something that's affordable to our population? Affordable meaning both in terms of the contributions that are charged, but also, if an employee needs to use their plan, are they going to be able to afford it? Or is the deductible so high that it's pointless to even offer this because if they have a service and they have to spend $4,000 before the plan pays, if that's going to bankrupt them, what's the point of this plan? Need to consider competitiveness. So, and Chris will talk about benchmarking later, but, are we offering plans that are in line or better than our competitors? Or do we have a risk of, our employees are going to go down the street and work for our competitor because their healthcare is so much better? Choice for employees is a big issue, right? Again, you want to make sure that you're offering plans that are right for the employee, and each employee is different. So you need to consider the kind of the broader needs of your entire workforce. What's right for me might not be right for Chris. If you have a diverse workforce, you're probably going to need to offer a few different types of plans. And then, if you have this goal in mind and you're offering plans that are right for some, not right for others, or you're offering multiple plans, you have an alternative health plan that might be confusing, you probably want to consider integrating that with some sort of employee navigation or an open enrollment tool, some kind of communication. I know communication tends to get ignored sometimes from your employer, but like you really need to make sure that your goals are aligned with your employees' goals, and it's clear to everyone why the plans are what they are, right? And going back to the original question, like, why is this plan cheaper than this plan despite it seeming richer? It would be nice if the employer had answered that question, right? Because that really should be the goal. Okay. So, and hopefully this is very much a review, but the basics of plan design, the components of what makes a plan what it is. Deductible, this is, the amount that the member has to pay before the plan is going to pay for anything, typically. Copays are a fixed dollar amount that a member pays when they use a service. So office visit copay of $20 means the member pays $20 no matter how much that office visit costs. Coinsurance is the opposite. So that's a percentage. That is, the percentage is fixed, which means that the dollar amount that someone will pay will vary based on the cost. So you see a specialist, it's a 20% coinsurance. That specialist costs $200, you're paying 40. That specialist costs $300, you're paying 60. And then out-of-pocket maximum, that's the limit that you would pay in a given year. So the out-of-pocket max is $3,000. No matter what you have in care that year, you will spend at the most $3,000. These components tend to determine what the richness of the plan is, and richness is a way to think about what percent of the plan of total claims the plan will pay for, and that's what actuarial value is. Actuarial value is simply plan paid claims divided by plan paid plus member paid claims. So it's the percent that the plan is responsible for. So just to kind of put an example on this, just made up this plan, $500 deductible, $3,000 out-of-pocket max, 90% coinsurance, and so on. This plan would have an actuarial value of somewhere around 90%, let's say. So on average, the plan will pay for 90% of claims. The members will pay for 10% of claims. But this plan will feel different to different types of people. So it's the exact same plan, but depending on how much you use the plan will dictate what your experience is like. So someone who doesn't use the plan very often, they might just go to the doctor, they might have a couple prescriptions. None of this stuff really matters. They're not going to have a deductible to pay. They're not going to get close to the out-of-pocket maximum. Coinsurance isn't going to matter because it's copays that they're paying. So they're just going to pay, $20 to see their doctor. Maybe they have a couple $5 generic copays, and that's it. So their actuarial value is around 75%. They'll pay for 25% of costs, and the plan will pay for 75% of the cost, just, given how much doctor visits and drugs cost. For a moderate utilizer, they might have claims enough to at least satisfy the deductible, and they might have a little bit of coinsurance, right? So you get an outpatient surgery or you get a couple X-rays. That'll be enough to satisfy that $500 deductible. But what that means is that they're paying that 500 plus maybe 10% of a couple $100, and the plan is paying for very little because you have to satisfy that deductible before the plan is responsible for anything. So for this person, the plan's actuarial value, their own experience is only like 25%. It's a pretty raw deal for them. They're paying for almost all of the costs. And then for a high utilizer, let's say, they have claims of $55, $60, $75,000. Then obviously the plan is going to pay for a lot. The out-of-pocket maximum here is $3,000, so that's all they'll pay for the year. The plan picks up the remaining, $65,000, $70,000, and so for this person, that actuarial value is pretty good. It's around 95%. So all of that, like I said, plan design, benefit richness, actuarial value, that has a pretty significant impact on or an influence on member behavior. Right, a high deductible is going to potentially influence what a participant might feel comfortable doing. If they have an elective procedure, they might not get that because they don't want to pay, $3,000, before the plan starts to pay. It obviously has an impact on affordability. The richer a plan is, the more the employee contributions probably will be, but the less rich it is, the more responsibility the participant will have when they actually use the plan. Risk distribution between employer and employee and predictability of employer and employee costs, those are related, but the design has a pretty significant impact on who's paying for what, when employer is paying versus employee is paying, and how easy it is to, obviously a copay is very predictable for an employee, but less predictable for an employer. Deductible, the higher it is, the lower the employer's cost will be, at least early on in the year before that deductible is satisfied. So, it all has an influence on kind of cost and distribution of risk. Um, Trying to be cognizant of time here, so I'll try to keep moving. But here's just a sample of, like I said, most employers offer multiple plans, and each employee that's going through open enrollment is going to have a choice when they look at the plan design. And it's not always obvious what the right choice is. But this is a very simple exercise and we're actuaries here, so we can probably do a slightly more complex exercise. But like if, my brother or my friends are asking me, they'll send me their open enrollment information and which plan should I enroll in. It's a very simple exercise you can do to decide what the right choice is for you. So 3 questions. What if I don't use the plan at all? Which one will I spend less in? What if I only satisfy the deductible? What if I satisfy the out-of-pocket max? And you can do that calculation, factoring in what the monthly contribution is, as well as if the employer contributes anything to the HSA, if it's a high deductible plan. So in this scenario, in this sample that I created, if someone doesn't use the plan at all, they just pay employee contributions every month. So for the PPO, 200 times 12, they'll pay $2,400 for the year. For the high deductible plan, they pay $50 each month, $600, but they also get this $500 seed to the HSA from the employer, and that's their money. Even if they leave the company, that money stays with them. You roll it over every single year. It's portable. You take it with you. You can even use it to fund retiree medical, 50 years down the road. So it's your money. You can count it, subtract that from the contributions. So you only spend $100 for that year if you don't use the plan. So obviously, for a non-utilizer, the high deductible plan is the much better choice. For someone who only satisfies the deductible, it's the same contribution plus the PPO, it's a $500 deductible. For the high deductible plan, it's a $2,500 deductible. So we add 500 to 2,400, 2,500 to 100. High deductible plan is still a slightly better deal, even though the deductible is $2,000 more than the PPO. And then if you go all the way to the out-of-pocket max, this is where then the PPO becomes the better deal. Contributions plus out-of-pocket max, contributions minus HSA plus out-of-pocket max. Finally, so if you're going to really use the plan, then the PPO becomes the better choice. Like I said, since we are actuaries, we can do a slightly more complex exercise if we want. We can assign probabilities to each of these 3 scenarios. And so if you have a pretty good idea that, I think I'm probably going to be a fairly low utilizer, I'll put 60% here. I might satisfy the deductible, 30%. Very unlikely chance that I'll actually hit the out-of-pocket max, so 10%. And then that's how I create my expected value there. Okay, and then last section for me, we've been, or at least I've been kind of focused here on what the plan is responsible for. That's what actuarial value is. Actuarial value is the cost that the plan is responsible for. So richness is tied to plan cost, but it's not necessarily tied to total cost of care. And total cost of care is the plan cost plus the member cost. It's the denominator of the actuarial value calculation. So cost sharing is really, an 80% plan, the plan pays for 80% of spend, but it doesn't necessarily have an influence on how much is spent overall when you add those two 80% plus 20% together. That total cost of care is driven by unit costs, so how expensive a service is, provider mix, whether you're using inpatient or outpatient, whether the doctor you see is owned by a larger hospital, things like that. Pharmacy inflation, so drugs just continue to get expensive more year over year. The mix of drugs, you probably all have seen Ozempic commercials. Weight loss drugs are exploding right now, so that has significant influence on inflation for pharmacy. High cost claimants are both the incidence rates and the average cost of a high cost claimant are continuing to increase. And then how effective the care management is. So those people who have chronic conditions or are high cost claimants, are they getting the care that they need? Are they getting the right care? Is someone kind of with them the whole time to make sure that they're receiving quality care and whatever's wrong with them is being managed appropriately and hopefully taking them from a high cost claimant to a moderate claimant or chronic someone with chronic condition to someone with a managed chronic condition. So total cost of care, we refer to that as allowed claims, planned cost or paid claims, and then the allowed minus paid is what the member cost share is. Because there's a difference between planned paid and total cost of care, an employer really has a choice in how they manage their plan spend. They can cost shift, they can shift more of their cost from them to the members, or they can look to reduce those total allowed charges. Obviously, the easier of the two is to just shift more cost to employees. But if you're doing that, there are competitiveness concerns, right? The more you shift to cost to your employees, the more susceptible you might be to offering a plan that's worse than your competitors. There's also affordability concerns. So the more you shift to employees, the less likely it is that they'll actually be able to afford that plan. So both of those things are concerns. And as healthcare continues to get more expensive, employers have started to look at other ways to manage that total cost of care as opposed to just shifting more costs to employees. So again, this is just a simple example of your two options. For a plan that costs $10,000 all in, plan pay plus member cost share, of which the plan pays for 80%. If they simply cost shift and let's say we want to reduce our spend by 10%. If we cost shift, if we just take that 10% and make the members pay for it, well, you see that their costs go down by $800 per employee, but the employees' costs go up by $800 per employee. So these $10,000 did not change, but obviously their slice of the pie went down. So yes, they saved at $800, but was it the right way to save it? Alternatively, if they instead focus on managing the total cost of care, whether that's through, managing the network or, improving the quality of care that members receive or partnering with third-party vendors to manage chronic conditions, there are plenty of ways to influence total cost of care. If they cut that by 10% instead, their costs still go down by $800 per employee, but the members' costs also decrease by 10%. And so the pie, the makeup of the pie has not changed. It's still 80-20, but it's shrunk. Everyone together has saved $1,000. And so that is obviously a much more effective way of saving that money. It's a little bit more difficult to achieve. So with that, I will turn it over to Chris now.
Thank you, David. So how do I want to start this? Employers have to balance many competing priorities at the same time. If you go back to World War II, right, at the birth of the employer-based healthcare system that we have in America, which I encourage you to do. It's really interesting history. It was set up primarily as a talent attraction and retention tool. Employers offer benefits to attract and retain talent. At the same time, these are now becoming much more costly over time, right? The healthcare costs weren't such a big deal in the 1940s when this was the burden was first put on the employers. Now that cost has skyrocketed. Right. So you have that balance of I want to attract and retain top talent so people come work at my company, but I also need to manage my checkbook. So competing priorities. Additionally, when setting contributions, I want to think about what behaviors I want to incentivize my employees to take. So contributions are really an incentive mechanism to move them in a certain direction. This is not an exhaustive list of approaches to setting contributions. And there could be many more. You can be an employer, you can make up really whatever approach that you want. There are very few regulations that restrict how employers can set contributions. So generally, at the beginning of the year, the employer, the company will set some sort of guiding philosophy, right? What is the goal that they want to achieve by offering these benefits? And that will drive a lot of the conversation of, okay, where do I set contributions in order to align with that philosophy? Now, healthcare benefits is pretty interesting. In the world that David and I work with, that all these companies are self-insured, right? They're not fully insured, they're self-insured, which means that they're governed by the federal regulation and not the states. We don't even have to do the work that we do. You don't even have to be an actuary. Technically, the healthcare budgeting for our clients, for a self-insured client, has a 1-year time horizon, right? So retiree medical, and I don't work in the fully insured world, but maybe there's a bigger time horizon there. When you have that longer time horizon, okay, that's where you need government regulated. You need to be an actuary. Here, it's only a 1-year time horizon. The government did not regulate that an actuary needs to be involved in the budget setting process, contribution setting process. Our clients greatly prefer it, right? There's a lot of trust and credibility inherent in those letters next to our names, but you don't need to be an actuary. All that to say is that this is fluid. It's dynamic. What is the approach and philosophy 1 year can be very different the next year when a new leadership comes in, right? Leadership, when we see leadership turnover, they have a different vision for the company. They have different experiences of what worked in the past. They're going to implement some changes, and that'll flow through into the contribution approaches. And I also want to make clear that you're not going to see just one of these typically. Sometimes it's a combination, or most times it's a combination of a number of them. So I'll touch on a couple different ones. Fixed percentage of premium. At all times, we're going to start with a projection of what we think costs are going to be in that next year, total costs, right? So a lot of times they'll set contributions by a certain percentage of those projected costs. So if costs are projected to go up 10%, then contributions are also going to go up 10%, and that percentage of total cost that remains flat from year to year. Defined contributions. We see this more in the retiree medical world, where employers are trying to get out of the game of offering insurance and they want to really limit their exposure. So they'll set a defined dollar of how much they want to subsidize, not a set percentage, a defined dollar, right? So as costs increase year to year, their dollar amount that they want to pay remains flat, so that all increases go on to the employee. So that creates this, what we call a leveraging effect. And you see a lot of really, really big increases in contributions in this approach. Competitive positioning. The biggest question we get from our clients is, what are our competitors doing? What are others doing in the market? So again, this is a talent and attraction and retention tool. So they need to know how their contributions line up with contributions of their competitors in business. Value-based contribution strategies. If I deem one plan more valuable, I think I'm going to get more bang for my buck for people who are in this plan over here rather than this plan over here. We'll see an example of that. Then I want to migrate them. I want to incentivize them to migrate from the low value plan to the high value plan. And I can do that through contribution settings. I can set the high value contributions low, the low value plan contributions high. And then salary bands, right? If I want to be cognizant of affordability, right? That lower income people don't, like $100 to somebody who's making $50,000 is very different than somebody who's making $150,000. So a lot of companies choose to vary the contributions that they collect by salary bands, so that the higher salary bands are essentially subsidizing the lower salary bands. So again, you'll get a combination of all of these. You go to the next slide. Just some considerations in setting that philosophy. What are my goals of the plan? Where do I want my employees to go? How important is cost predictability, right? If I have that defined contribution, I can predict what my costs are a little bit better. But if I'm just sharing a certain percentage, right, then if I have a bad year, I feel that, and everybody else feels that, and we kind of share in that. Then are my plans affordable, right? What's the average pay of the population, of the employee base that of the business that I'm in, right? Do I have a factory line? Do I have high paid executives, right? Do I want to vary benefits between the two populations? Do I have unions that have contracts that make me not that limit my ability to set contributions? And then are plan costs equitable, right? Does everybody have a similar access to healthcare? And are my plans even offering a meaningful level of coverage? Even if they pay for it, does my plan offer a meaningful level of coverage, right? So that'll all go, there's a lot of pie in the sky, vague, and amorphous conversations that happen before the nitty gritty math of the plan year happens, and that'll guide the choices guide the choices of the decision points throughout the year. If you go to the next slide, we'll go through an example to kind of show you exactly what I'm talking about, right? So let's say we're setting contributions for 2027, right? So here's we'll start with the current state, 2026 current state. I have 3 plans: a high deductible plan, a PPO plan, and an EPO plan. Remember, that EPO plan is that limited network. I have a limited number of in-network providers. I have no out-of-network coverage. So I'm really steering everybody to that in-network, right? So I get a lot of value there. And I'll explain that in a little bit. So I've set my plan cost here. It's just an expectation of what I think the cost will be in 2026. The contributions are set below that, right? And then on the right, I showed contributions as a percentage of plan costs. And you'll see that the HDHP, the high deductible plan, is the lowest plan, both on a dollar basis and a percentage basis. This is because back in the day when high deductible plans were introduced, there was a thought that if you set the deductible high and the individual had some pay, all 100% of costs before that, it would introduce a level of consumerism, that they would go out and shop for the lowest cost provider, or distinguish between providers based on quality, right? Make sure that they're making a good choice. Turns out that was really difficult to do, right? That cost information is not readily available. So it really didn't pan out. We didn't see that consumerism. Really what we did is we saw all the healthy people that are not utilizing the plan anyway, they moved all to the high deductible plan. So really it hurt the employers in a lot of cases because they were losing contributions from the PPO plan, where the contributions are high, right? These people are not utilizing the PPO plan. They moved to the high deductible plan, still not utilizing the plan, and now they're paying less contributions. So that idea didn't really work out. But that was a popular theory in the marketplace not too long ago. So if you go to the next, right, now we're going to project 2027. I'm going to take my claims, top left table. I have all my claims. So for each year, I have about $4 million in claims. Then in the next table, I have adult equivalents, right? And what this means is not everybody's going to cost the same. If I say an employee, that counts as one. A child probably counts as 0.5, right? And that's pretty standard. So let's say that each child counts as 0.5 because they're going to utilize the plan. They're healthy. They're ramp up, they're running around. They fall, they get right back up, right? So they're not utilizing the plan a lot. So they're going to cost a lot less. Typically, spouses are the contributions to cover a spouse are much higher than to cover an employee or a child because they don't work for the company. The company doesn't want to pay for that spouse. They generally have coverage elsewhere through their employer. So each company wants to incentivize spouses to get off their plan and go on to their own plan or a different company's plan, get coverage elsewhere. The first people to leave will be the healthiest spouses, leaving only the unhealthiest spouses. So typically we assume spouses cost more than an average employee. So that's the adult equivalence, just varying what we think each individual costs, right? Accounting for that in headcounts. Then we get a per adult equivalent per year, essentially just claims divided by headcounts. I'm going to trend all of that to 2027. Healthcare trend is much greater. This is just assumed healthcare trend, right? Much greater than just common inflation or even GDP. That's why we hear so much about it in politics, is that healthcare costs are growing more than the general economy. That's a problem when your healthcare accounts for more and more and more as a proportion of your total economy, right? So we trend all of these to the same year. We're going to trend all of them to 2027. So I'm going to hit these per PAEPYs in the bottom left box by my trend adjustment factors. Then I get my trended PAEPYs, right? These are all on a 2027 basis, that middle table on the right. So now I have my total costs on a 2027 basis. I'm going to blend 3 years of experience, 25%, 25%, 50%. Generally, I'll heavily weight that last year, come up with an average cost, compare that to my current cost, I increase 12%. Be mindful of time. I'm going to run through the next slide, right? So now I take that, I have my actuarial values. This is a common way to build the relative costs by plan, right? So I'm going to take my total average cost, I'm going to hit it by my actuarial values, and then my tier ratios, right? My spouse is 1.2, my employees counts as 1, right? My spouse counts as 1.2, right? So together that my employee spouse should cost 1 plus 1.2, that 2.2. My children, even though I count each child counts as 0.5, I assume there's more than one child. I assume children as a general count as 0.9 of a person. And then a family builds up from there. So now I have plan costs by plan, 2027 plan costs by plan for each of the tiers. And if I just kept the same, now I'm looking at the middle tables, if I just kept the same percentages, right? These status quo contributions, that 112, 448, 224, that would be if I kept that same percentage of costs, right? So my cost grew 12%, contributions are going to grow 12%, and my subsidy percentages stayed exactly the same. But let's say this year I changed my mind. That high deductible plan is not working out as intended, right? I'm not seeing savings from the high deductible plan. Where I will see savings, I know I will see savings if I migrate people to the EPO plan, right? Because I was able to limit the amount of providers in the network. Because of that, I'm steering more people to a smaller number of providers. Those providers in that EPO network are going to agree to a deeper discount on that service. So say a knee replacement in the high deductible plan, because there's so many providers and so many options, that provider is not going to agree to a deep discount. Let's say it costs $1,000, a knee replacement in a high deductible plan. Pretty good deal for a knee replacement. In the EPO plan, because there's that steerage to only a fewer number of providers, that same provider that charges $1,000 in the high deductible plan, he'll agree to only take $900 in the EPO plan because that narrow network has steered steered more people to him. So he's banking that even because he agreed to a lower discount, he's going to get more people to him, right? So there's this negotiation between the carriers that are determining the network and the providers that are agreeing to participate in the network. I went through that fast, so I apologize, but I do want to be mindful of time. Next is benchmarking, right? I said it at the top. The most common question we get from our clients is, what are competitors doing? Again, this is a talent attraction and retention tool. So they need to make sure that they are in line with those they're competing with as a business. So if you go to the next slide, these are actual exhibits that we show our clients. So you get a really good insight into like how things are determined and what the process looks like. This is that total cost of care that David was talking about. The purple is the employer cost. The yellow is employee contributions, and then the pink added on top are employee out-of-pocket costs. Things like costs before the deductible, co-pays, co-insurances. So this is the total gross medical cost and how it stacks up. In total, that's the total database. Industry is the industry-specific cut of the database, of the benchmarking database. And then employer is our specific employer that we're consulting on. So in this situation, right, let's look at it real quick. So I see the total. I'm going to look towards really to industry, right? I want to compare to my competitors, not the total database of people. I'm not super worried about that. But let's look at employee out-of-pocket costs, right? 9% in the industry, 7% in my employer. That means my plan designs are richer than the benchmark, right? Let's look at contributions. 17% for the industry, 15% for my employer. It means my contributions, my employee, the cost my employees are paying is less than the industry. I'm doing really well. My plans are better, richer than the benchmark. So I could even think about considering taking my foot off the gas. Maybe I don't want to be too far ahead of the market, right? I want to be ahead of the market or with the market, but not too far ahead of the market where it's considered too expensive. Maybe I'm spending too much money here. Go to the next slide, right? We could see that same thing. Here, the purple is the industry, orange is my contributions, but industry total employer. Anyway, we'll look at employer versus industry, right? So you'll see that the employee contributions are 10% of total costs. Well, the industry is also 10%, right? So that's good. I'm very in line. Dependent contributions, like I said before, right? They want to get spouses off the plan. You'll see this with almost every single employer that spousal contributions, dependent contributions, particularly spouses, are going to be way higher than employees, right? Because they're not working for the company. So my employer's charging 21% of cost. Industry's about 20%, right? So it's pretty in line. So 16 as total, or every individual, contributions are about 16% of cost. Industry is about 15% of cost. Very in line with my industry benchmark. And these don't have to be consistent from slide to slide, right? Like this is just an example but this is an actual slide that we send to a client. And then the next slide is looking at the total cost. So if we ignore contributions for a second, we just want to see how efficient the program is running. How efficiently are you managing gross medical costs in your plan? So we have the unadjusted best benchmark. That's just but everybody in that benchmark has different characteristics. So what we'll do is we'll adjust that benchmark to look more like our specific employer to get a more apples to apples basis. So we'll adjust for age, gender, right? So our benchmark, we're increasing the benchmark by 7% to adjust to the age gender mix of our specific employer. So they're probably older than average. Family size, we increased 4%. They probably have larger family size. Geography, we decreased 6%. So my client is in a cheaper geography. So we're going to decrease that, right? And now we look at our adjusted benchmark, and that's an apples to apples basis on my employer, and I'm still below that, right? I'm below where I would expect based on benchmark. So my plan is running effectively. I'm managing costs well, implementing programs, steering individuals to the right areas. Uh, you know, I'm doing a good job managing the costs of the plan. That was a lot, right? So sorry for running through that. Definitely a lot of information. Want to open it up for any questions that anybody wants to ask live.
There were several questions, but Chris, I believe you answered most of them. So thank you for that.
Cool.
And I see a new question that David answered, and it should be visible to all our attendees. We can wait for another minute or two if anyone else has any questions. I can ask one question, I guess, while I have
Sure.
you. So I noticed that the factors changing from like just one employee to with the spouse, child, all family, they were same for all options, like high deductible.
Yeah.
In the past, I observed that just one case, one example though, but the rate was so high for the family on the high deductible versus if it was PPO, it was a lot
Right.
lower. So is that the leadership philosophy? Like what made them to go that route?
So I want to clarify, are you talking about contributions
The premiums.
the premiums that you're paying?
Yes, the employee
Right.
has to, yeah,
So
contribute.
there's two tier we call them tier ratios, right? Like so the coverage tiers are employee plus spouse, and the
Mhm.
ratios are how they all compare to the employee, right? Employee only. There's two sets of tier ratios that don't have to be the same. One for the total cost projections, and then tier ratios for the contributions. So the tier ratios I showed before, um, they were for the premiums and they should be very consistent from plan to plan. But the contributions, it's kind of like the Wild West and they can set them however they want. So again, it's an incentivization thing. So they want to incentivize those families from that one plan that had a high tier ratio. They want to incentivize them to move to another family. So it's just a decision of where they want to incentivize people to move. It's not so typical, right? Generally, they are fairly consistent, but sometimes if they want to move people from plan to plan, they can do whatever they want with the contributions. It's a little bit more. It doesn't make sense mathematically to have different tier ratios by plan for your projections, but contributions you could do whatever you want.
So they wanted the family specifically to move there. Okay.
Maybe it could also just be a mistake, right? It could also just be somebody made a mistake. Somebody did it 10 years ago and it's just been carried forward year to year to year and they don't want to upset the apple cart, right? They don't want to like have this drastic change. Oh, why didn't these people increase while everybody else increased? Well, we're catching up from a thing that happened 10 years ago. People don't like that sometimes.
Right.
It could also be a risk thing. So when you underwrite a plan or when you underwrite multiple plans, you generally don't want to underwrite specific to each of those plans. You want to underwrite for the group as a whole and then allocate based on actuarial value across the plans. But when you're setting contributions, you can adjust those for the actual risk of the individual plan. So if you happen to have a lot more unhealthy people or costlier people in one plan, and you're trying to maybe move them to lower cost plans, you can adjust the contributions so that it does achieve some of that. That could be another reason. But yes, Chris's answer was good. Do we have time for one more, or are we out of time? We do have another question, but
I don't see the question. Oh, I see the question. Okay, yes. One more minute and let's answer. Can you comment on how AI is or could be used by employers and employees to choose among several different health insurance options made available at open enrollment?
And Chris, this is going to be a question for you. You're the AI guy, so go ahead.
Right. You say AI once, and then you're the AI guy. So it's being as like a as a tool. During open enrollment, you could talk to, like, a lot of our clients are implementing some sort of chatbot that you can talk to and tell it a little bit about yourself, and it'll guide you to the plan that's best for your specific situation. So if you're a high utilizer of the plan and you go to the doctor all the time, you have a condition that you need a lot of maintenance with, it'll guide you to the high value plan, right? Or if you're young and you don't use the plan a lot, it'll guide you to the lower value plan. But it's something to talk to, and it'll demystify a lot of these complexities. What's a deductible? What's an out-of-pocket max? If I spend this amount, how much am I going to have to pay for it? How much my company's going to have to pay for it? You could ask it a lot of questions, and it's doing a lot of good there to navigate individuals to the correct plan.
So they don't have to be actuaries, I guess. Then
No,
they
you
can
don't.
do
Yeah,
yeah.
just to choose a health plan, you shouldn't have to be an actuary to
Yeah.
navigate, right? To choose the right health plan.
Uh, but thank you for that. Yeah, I don't see any other questions. And yeah, thank you so much, Chris and David, for your presentation.
Thank you.
So I'll turn it to you, Tim, for the introductions for our
Yes.
next session.